Hi, everybody. This is a very important webinar organized by the European chapter of the Academy of Eating Disorder. I'm starting again.
Yes, please. Everybody,
Okay.
please remember to turn off your, other than the speakers, turn off your,
Micro.
yeah.
Mute yourself, okay?
Yep.
Okay. Welcome to everybody. The webinar is an important moment for the European chapter of eating disorder of the Academy, because we treat the specific aspect of the target group composed by people LGBTQI and plus. They are a specific group, and that we need as clinicians to understand more their needs, to improve the quality of the assessment and the care for them, respectfully. Recently, the APA insert inside their organization the division on equity, diversity, and inclusion. Also for us, as an Academy and European chapter, is important to understand and to offer the opportunity to meet and to go in deeper way inside this kind of group, also understanding the difference between gay and lesbian and transgender, to offer them the moment to help their history to become really free, respect, and insert in the society, thanks also to our help, because we are here to help our patient and their family and their loved one. Today, there's a very important group of presenters. There's Jason Nagata, Keile Ganson, Paolo Meneguzzo, and Maglio Converti. They present three talks. The first talk is together by Jason Nagata and Keile Ganson. Jason Nagata teaches in the University of San Francisco, University of California in San Francisco. She's a doctor, she's a pediatrician. She edited a long list of articles, and specifically he treats problem about adolescent young people in the eating disorder and the gender, sexual orientation. He also, with Keile Ganson, organize and manage and lead a research on the eating disorder in young gender minority and transgender people. Okay, thanks, Jason. To you.
Thank you so much. I'm just going to pull up my slides. Thank you, everyone, for joining and for inviting us to speak today. And I also just wanted to mention that I will be co-presenting with Keile Ganson. So as an overview of our portion of this talk, I will start by talking a little bit about gender norms in general and how these can affect body image and eating disorders in all types of LGBTQ people. And then Keile is going to focus on sexual minorities, including definitions, diagnosis, and clinical considerations. And then I will talk about gender minorities and similarly talk about definitions, diagnosis, and clinical considerations. So just to begin about gender norms, I wanted to just highlight that, as many of us know already, the feminine body ideal really prioritizes thinness. And this is really reflected through a lot of different influences. So even if we think about the dolls that girls play with from a young age, like how thin and skinny these Barbie dolls are, even to the media portrayed feminine ideal in Hollywood movies or television or Netflix. And then also more recently in the last decade or so, the impact of social media on girls and their body image. And this is from the Facebook files about a year ago that were released, showing that Facebook and Instagram were aware of some of the impacts that these social media platforms had on girls' body image. Now, if we contrast that, actually, the behaviors or these weight loss goals will lead to certain disordered eating behaviors. These are some of the classic eating disorder behaviors like fasting or skipping meals, severe restriction of food intake, vomiting, laxatives, and diuretics. In contrast, if we think about the masculine body ideal, and this is work that Kyle and I have spent a lot of our careers working on, this in contrast really promotes muscularity and pursuit of being bigger and bulkier. And so this can lead to a whole nother set of ideals and behaviors. And so just as the corollary, these are Batman and Superman action figures from decades ago. And research has actually shown that over the past 30 years, muscularity pressures have actually increased. So if you look at the Batman and Superman figurines that our current children play with, they're actually more muscular than they were previously. And this also is reflected in Hollywood. So if you think about some of the traditional Hollywood stars from decades ago and the ideal body image they portrayed, and you compare them to perhaps the current rock or Marvel superheroes, the current pressures for even Hollywood actors are much more muscular and big. And then similarly, if we think about pressures on social media, similarly, people are portraying these body ideals. And so here you can see on the right is Cristiano Ronaldo. You see he has 500 million followers on Instagram, and most of his posts, depict muscularity like this one. And then since we're talking about sexual and gender minorities, this is an influencer, Max Emerson on the left, who was actually featured for being what they colloquially call an Insta-gay. And this is his sort of posse of people. And, you can also see the sort of ideal body image that is portrayed among his followers. And so even though most of the research has really been on girls, there is a growing body of research showing that actually Instagram and all of these factors do affect boys and men, and these can promote those muscularity ideals. So boys are actually more likely than girls to allow for public following. Selfies of males are more likely to be full body photos that show muscles, and content analyses of male body image related Instagram posts have shown that they depict muscularity and leanness. And this can similarly lead to behaviors or attitudes such as muscle dissatisfaction, use of anabolic steroids, which promote muscularity, as well as meal skipping and disordered eating. Now, these masculine ideal pressures can lead to muscle enhancing behaviors, which may be less understood than the classic eating disorder behaviors, but some of them may include actually protein overconsumption while restricting carbohydrates and fats, engaging in cheat meals, which could be synonymous with actually binge eating, and then bulking and cutting cycles where for some period of time people are having a caloric overflow and then cutting, so having a caloric deficit. The overflow is to try to promote muscularity, and cutting is to try to cut fat. And then also use of appearance and performance enhancing drugs and substances, so muscle building supplements, including anything from anabolic steroids to androstenedione, creatine, and there's a numerous list of muscle building products out there. And finally, compulsive exercise. So this is just a backdrop of some of the pressures in terms of gender norms that promote the feminine body ideal and the masculine body ideal that I think really permeate some of the pressures that LGBTQ people face. And so with that, I'm going to actually transition to hand it over to Kyle, who will talk about sexual minorities.
Awesome. Thanks, Jason. Let me pull up my screen here. Okay. Okay, so first I'm just going to provide some basic information about some definitions, as Jason was mentioning. It's good to just have this background. So When we talk about sexual orientation, it's good to think about this as a multi-dimensional construct. So it's not just a single sort of I'm sexually attracted to or have sexual experiences with people. There's actually these three components. One is sexual identity, which is how one identifies oneself, such as, and I'll talk about these, in a few minutes, but heterosexual, gay, lesbian, etc. There's also attraction. So whether or not you're actually sexually attracted to the same or other sexes or genders. And then, of course, there's actual sexual experiences. So what kind of people who, based on gender, based on sex, that you actually have intimacy with. So sexual orientation is sort of like focused on those three components. And that can be, there's always not always concordant between those different identities, those different attractions, and who you have sexual intimacy with. So it's good to be thinking about it not as strictly, like black and white. Like someone says they're one sort of sexual or identity or orientation. That doesn't necessarily mean that they, follow that all the time, or they might have attraction towards certain people. And it's just a good knowledge to have as you think about assessing people in your practice. Generally, as someone, we use the term sexual minority. This would be someone who has a sexual orientation that differs from the majority of the surrounding society. So, for example, I think in like North America, for example, like someone who identifies as gay, lesbian, bisexual, etc., would be considered a sexual minority because you're comparing that to the heterosexual individuals, which obviously make up a much larger majority of the population. So it's important to note that there is obviously that discrepancy there. And of course, when we talk about sexual minority, and I'll talk about this in a few minutes, but that's an important component as well, just to think about why eating disorders and related behaviors might be more prevalent among this population. That minority status holds a lot of weight in that. And so thinking about the sexual identities, there's certainly a long list. I named a few here, like heterosexual, gay, lesbian, bisexual, pansexual, asexual, and demisexual. Obviously, heterosexual would be being sexually attracted to people who are opposite sex. Gay or lesbian would be people who are sexually attracted to and have experiences with people who are the opposite. Who are the same sex or gender. Bisexual would be sort of more open and attracted to people of any gender. Pansexual is a similar sort of sexual identity, where it is people who are of all genders as well. Asexual is more of a spectrum, where people who have different levels of not a lot of interest in sexual experiences. And then demisexual is sort of only being sexually attracted to people who are you have an established like emotional bond with. And so these are just a few that I just pulled out. Of course, there's definitely a long list of them, and they are ever changing as people, I think, explore and identify with different sexual orientations. Because it is certainly a spectrum, as the sort of sexual orientation definition exemplifies. Oops. So this is a model that was recently published in a paper that was tested, that I think is an important theoretical conceptualization based on some of the information that Jason presented earlier about sort of media pressures or pressures in the community, and also in the LGBTQ community itself. So you can see that there's these pressures that we experience living in societies where around body image. And so, as Jason mentioned too, there's obviously the thin ideal and the muscular ideal. And so from there, if you experience these pressures through social media or your peer groups, that can lead to, of course, thinness-based dissatisfaction or muscularity-based dissatisfaction. But then, of course, it's really important, and that's all part of the tripartite influence model, this idea of these different pressures, media pressures, social pressures. But then there's also this minority stress theory, where people who are of sexual minority status within the context of being a quote unquote minority, they might experience discrimination or marginalization or oppression, which can lead to things like sexual orientation concealment, where maybe they feel pressure to actually conceal their sexual orientation, which can inherently lead to maybe thinness-based dissatisfaction and then obviously the other sort of behaviors. And then similarly, like internalized homophobia might lead to muscularity-based dissatisfaction. And of course, once you start to have these dissatisfaction, you might feel these pressures and discrimination based on your sexual identity. You can obviously move into the space of actually engaging in disordered eating behaviors or muscularity-oriented behaviors. So like dietary restraint in order to achieve a thinness-based ideal, or to achieve, if you're dissatisfied with your body and you want that thinness ideal, You might, do some dietary restraint. Similarly, for males who maybe are interested in building muscle to fit a particular ideal within their community or the pressures on social media, along with obviously dissatisfaction with current muscularity, engaging in anabolic steroid use or compulsive exercise or weight training or some of the behaviors that Jason mentioned can obviously be led to there. So I think this is a good model just to frame when we think about what's happening for sexual minority individuals when it comes to being more commonly prevalent, like eating disorder behaviors and diagnoses being more commonly prevalent. We can frame that information within this larger context of the general sociocultural pressures that people experience, as well as the unique discrimination and experiences that these individuals have within society. So I'm going to go over some statistics here just to kind of give you a little bit of a background of like the epidemiology of eating disorder behaviors and diagnoses. So this is a study from 2020 that actually looked at DSM-5 eating disorder diagnoses among sexual minority individuals. And they found that there was roughly 2 to 4 times greater odds of an eating disorder diagnosis, including anorexia, bulimia, or binge eating disorder among sexual minorities in the US. And this is a nationally representative sample, so it actually gives us some really good information that these individuals are more likely to experience eating disorder diagnoses. And so they estimated the prevalence of anorexia being roughly almost 2%, bulimia being 1.3 or a little over 1%, binge eating disorder being a little over 2%. And now I think something that's important to be considering also is, and I'll talk about this in the clinical implications section, is that many of these individuals might be missed in healthcare settings. And so it could be that these diagnoses, these prevalence numbers would actually be higher if we had better knowledge among providers, if people of sexual minority status felt more comfortable seeking healthcare in certain settings, or just generally being more comfortable in healthcare settings at all, these types of things, like these numbers might actually go up. And other research, which I'll go into a little bit more in detail, has found that eating disorder behaviors among this population are also higher compared to heterosexual individuals. So that would include like fasting, skipping meals, vomiting, etc. And I'll share a few more nuances to that here. And so for adolescent boys, and I pulled some data from the US and the UK, but of course there's data elsewhere as well. Prevalence of fasting was about a quarter of males. And then same with diet pills, about 15%, purging via vomiting, about 17%, and of course, greater lifetime use of anabolic steroids, particularly among those who identified as gay. Sorry, it should say gay. I picked that up there. So gay boys compared to heterosexual, bisexual, and unsure. Similarly, in the UK, gay or bisexual boys had greater past year prevalence of purging behaviors, binge eating, and any restricting behaviors, which was higher than their heterosexual counterparts. And of course, gay and bisexual boys also endorse greater body dissatisfactions and increased pressures to increase muscularity, again, compared to heterosexual peers. So again, this data just exemplifies, I think, some of the nuances that Jason presented in like some of those images that, boys as particularly influenced by social media and pressures around their body, and of course, being also maybe potentially discriminated against for some capacity may increase their desire to change their body and engage in these behaviors for some specific purpose. And similarly, data from adult men, generally EDEQ scores, so scores in the eating disorder examination questionnaire, including all of the subscales, are generally higher among cisgender gay men, for example. And 4% are clinically significant for eating disorder EDEQ global score. So kind of giving an overall picture of someone's attitudes and behaviors related to eating disorders is actually quite high. 20% report any dietary restraint, 11% report binge eating, 10% reporting excessive exercise. So a pretty fairly high percentage of people within this community are engaging in eating disorder related behaviors and eating disorder attitudes. Now, as far as adolescent girls, lesbian adolescent girls have greater prevalence of using diet pills, purging via vomiting, and greater lifetime anabolic androgenic steroid use, similarly compared to heterosexual, bisexual, and unsure girls. So, this is, again, even surprisingly, like, almost 10% or so reported anabolic steroid use. I think that's quite a novel, interesting finding. So we got to think about how, as well, for females, they're feeling all those pressures as well. They're maybe influenced by their peers. They're influenced by the social media. and also being maybe potentially discriminated against, which then leads to these behaviors. Mostly heterosexual and lesbian and bisexual adolescent girls commonly engaged in purging behaviors, whereas about 17% reported binge eating, and this is data from the UK as well. And again, the pattern continues for the US in adult women. Cisgender lesbian women report dietary restriction over almost 14%. About almost 10% report binge eating, 5% report excessive exercising. So similar to the boys, similar to the adolescent girls, adolescent women are experiencing these behaviors at pretty high prevalence as well, and concerning prevalence for us to be thinking about in clinical settings. This is some data from the PRIDE study, which Jason has worked on, showing EDEQ global scores among that sample. And so they broke it down by gay men, bi plus men, lesbian women, and bi plus women. And so you can actually see kind of a trend in the scores here, that there is pretty high levels of scores for global scores, for shape concerns, weight concerns. And so it's important to be thinking about not only the nuances between the different communities, for example, gay men compared to lesbian women, and what sort of concerns they might be having. Like, for example, lesbian women have much higher weight concern, whereas men have a little bit higher, shape concern. So there's some nuance in how people are experiencing their bodies based on their sexual identity. And so that's just something to sort of highlight and emphasize as we think about this population. And this is some recent data that's currently under review right now, but we looked at, and this is from a study that I conducted, and Jason is one of the co-authors as well, but we looked at the intersection between gender and sexual identity, which I think is another important. Jason's going to talk a bit more about gender, but of course we can't think about sexual identity as being totally like separate or divorced from gender, because of course there's nuance there. And I just put the red box around women here, but generally the main takeaway from these data is that if you have an intersecting minority identity, so for example, if you are transgender, for example, or if you are a woman and experience like you're a lesbian or something, the scores are actually higher. So the trend is generally that like as you experience more minority identities, the greater the EDEQ scores are. And again, the lowest generally is among cisgender heterosexual men, which again, in our sort of society, these people would be sort of most privileged. Then again, of course, it's also important to know the limitations of the EDEQ and how it captures different behaviors and attitudes, specifically related to fitness orientation. But again, the sort of intersection of these identities obviously creates some sort of challenge for individuals where eating disorder attitudes and behaviors become quite high. And then this is a similar table that looks at just the individual behaviors, so vomiting, laxative use, compulsive exercise, dietary restraint, and binge eating. And again, the same sort of story is there, that as you sort of have these intersecting minority identities, the greater the eating disorder behaviors are, the more prevalent they are. So again, we have to be thinking about sexual identity and orientation not as divorced from gender, because obviously that is an important component here as well. And then importantly, we should also be thinking about muscle dysmorphia. Jason mentioned some of the behaviors around muscularity-oriented concerns. The MDDI is a very commonly used measure for muscle dysmorphia symptomology. And so there's 3 subscales, and then there's of course a total score. And you can see there's the different subscales are drive for size, appearance intolerance, and functional impairment. And so you can imagine drive for size is much more around drive for muscularity, desire a larger body, more musculature. And so you can see here, not surprising that gay men have the highest scores around drive for size. Again, they are, maybe more aligned with that muscular ideal. Whereas of course, like bi women and lesbian women have like lower drive for size scores. And again, not surprising that the men have higher, let's say, MDDI total scores, because generally men are more likely to be driving for muscularity or wanting a more muscular body versus women in general. Interestingly, I think something that I often find in the MDDI is that and it's emblematic here too, is that women often have higher scores around appearance intolerance and sometimes functional impairment as well. I think that for me, my interpretation of that is that women generally internalize or have greater body dissatisfaction than men do when it comes to the MDDI. I'm not sure exactly why that might be, but it is something that I've noticed in some of the data around the MDDI. And so it's something to be thinking about, that men might actually have gay men, for example, might have a very strong drive for size. They may be engaging in a lot of these muscularity-oriented behaviors, but their appearance intolerance or their body dissatisfaction might actually be lower than we would conceptually think it would be. And some of that may be due to that the behaviors that they're engaging in are actually working. Like, for example, if they're using steroids and they're gaining muscle and they're becoming more toned and lean, they probably won't have as much muscle appearance intolerance because it's working, right? So just something to think about. So yeah, this is just another, good to be thinking about the muscle dysmorphia component or drive for muscularity aspects of this as well. And just to kind of wrap things up, I think it's important. These are some clinical implications, things to be thinking a bit about. So as I mentioned in that really nice figure, these eating disorder attitudes, behaviors, diagnoses, they don't occur in isolation. So we need to be thinking about the nuances of these experiences among these individuals. And they're often comorbid with depression, self-stigma. Of course, this may complicate treatment and assessment. So we need to be aware of that when people present with depression, when people present with anxiety or body dissatisfaction. Further understanding what kind of behaviors they're engaging in will be very helpful. As I showed in the figure as well, like many contributing factors lead to eating disorder behaviors or are associated with eating disorder behaviors among this population. So that can be minority stress, heterosexism, sexual objectification, and the list goes on, right? Sociocultural pressures that may be unique to these populations, or again, like unique pressures that are within specific communities. There are body ideals that are maybe specific to like gay men versus bisexual men versus asexual men, for example. So thinking about what are the unique body ideals within those nuanced populations, and how are those body ideals like perpetuated via social media or social engagement, things of that nature. Also really important to understand that there's lots of barriers to treatment for sexual minority individuals. So sometimes and oftentimes there's insufficient culturally competent treatment. So treatment professionals who have enough information, who know how to assess, they don't have enough maybe knowledge around what it's like to be identifying as a gay man, for example. There's often less support from friends and family related to eating disorder and body image among this community. So thinking about how support systems around this individual might not help them in their treatment process. And then lastly, little knowledge among providers about eating disorders. So even if someone actually goes to see a culturally competent, specialist around sexual minority, health issues, they might not actually have the eating disorder knowledge to assess and treat the person. So, of course, boosting not only knowledge among this community and the identities they hold, but also around eating disorder behaviors as well. So kind of to sum that up, clinicians need to understand the unique stressors and factors that contribute to the eating disorder attitudes and behaviors among this population, and that includes the body ideals that are present in these sexual orientation communities. And with that, I will pass it back to Jason. Thank you.
Great. Thanks so much, Kyle. And I will just move on now and talk a little bit about gender and gender minorities. So my presentation is structured similarly to Kyle's in that we will start off with some definitions. So sex and gender are actually different. Sex is the classification of an individual as male, female, or intersex, and this is based on combinations of physical characteristics like genitalia or gonads or chromosomes, and sex is independent of gender. Gender identity is a person's internal sense of being a man or boy, a woman or girl, or sometimes a blend of both or neither. Gender identity does not necessarily correspond to the sex that was assigned at birth. Gender expression is the ways people externally show their gender or are perceived by others, such as clothing, haircuts, and activities they choose or mannerisms they possess. In terms of different categories of gender, cisgender refers to someone whose gender identity aligns with the sex assigned at birth. Transgender is when the gender identity differs from the sex assigned at birth. And then for gender expansive or non-binary, this is when the gender identity is outside of the gender binary, so other than just a man or a woman. And so I will be talking a little bit about our research from the PRIDE study, which is a US-based study of sexual and gender minority individuals. And here is a table that shows how we defined cisgender man, woman, or transgender man, woman, based on those gender definitions above. And then I will just note that the gender expansive group includes many different gender identities that are even beyond non-binary. And so you can see a few examples of those. So like gender queer or non-conforming, gender fluid, bigender, and there are many other genders as well. So it's just to say that there's a real large diversity of gender identities. Now, gender minority populations may have higher risk of eating disorders for a variety of reasons, including stigma, discrimination, or stress, the gender norms that I had mentioned previously. And then for those who do not yet have access to gender-affirming care, there could also be reasons to try to lose weight. So for someone who is a birth-assigned female who now identifies as a man, they may try to lose weight in order to suppress menses or their menstrual cycle. And for someone who is a transgender woman or birth-assigned male, these sort of thinness-related feminine body ideals may lead towards weight loss goals. And this is a conceptual framework showing some of the different pressures in transgender people that was proposed by Allegra Gordon at Boston. And so you can see that, in addition to sort of the socio-cultural femininity and masculinity ideals that we've discussed, there's a lot of, I think transgender people in particular face a lot of oppression and stigma, transphobia, racism, sexual objectification, and these can lead to body dissatisfaction, psychological distress, and barriers to gender-affirming care, and that can lead to decreased access to gender affirmation or an increased need for gender affirmation that can ultimately lead to disordered eating behaviors or other weight and shape control behaviors like for muscle building. And then, of course, there are several individual, community, and structural factors that can also permeate throughout. So if we look at the data from the PRIDE study, which is a US cohort of adult sexual and gender minorities, we did ask all the participants to report if they'd ever been diagnosed with an eating disorder. So these are also likely underestimates because these are only people who had been diagnosed by a healthcare provider, but I imagine there are more who had never been identified or formally diagnosed. But even here you can see that the prevalence rates are quite high. So in transgender men, almost 11% said that they had been diagnosed with an eating disorder, 8% of transgender women, and then 14% actually of gender expansive people. So these rates are quite high compared to the general population. We also asked everyone in the PRIDE study to complete some questionnaires. And so this is data on the eating disorder examination questionnaire in the three groupings, so transgender men, gender expansive people, and transgender women. And you can see that in general, transgender women actually had the highest restraint scores, as well as weight concern and shape concern. And this was reflected in a higher global score. And this, I think, just reinforces some of those gender norms or femininity ideals. So for transgender women, they really had the most pressures, I think, for sort of some of the thinness-oriented behaviors. And then conversely, if we look at muscle dysmorphia, the opposite is what is seen. And so we see actually that transgender men have the highest drive for size, functional impairment, and that leads to sort of the highest muscle dysmorphic disorder index total score, whereas transgender women had the lowest, and then gender expansive was somewhere in between. So I do think that these reflect that the pressures that people face, or their sort of goals for muscularity or thinness, really aligns more with their gender identity than their sex assigned at birth. We were asked to just talk about some clinical considerations, and so there are many unanswered questions in terms of treatment and management of gender minorities with eating disorders, but I thought that I would just highlight three particular considerations that I think are important. First is that because of all the stress and discrimination that gender minorities face, there is a huge psychiatric comorbidity with the eating disorder. And so this was a study of transgender individuals from universities with eating disorders. And you can see there were really high rates of non-suicidal self-injury, suicidal ideation, and suicide attempts. So about 3/4 of transgender people with eating disorders at American universities did report past year suicide ideation attempts and injury, which is just an incredibly high amount if you think about it. And so it's just to say that there are often many other issues to consider, particularly with their mental health. This was a study, actually, I thought that was very interesting, that looked at the association between receipt of gender-affirming care and then EDEQ scores. So this was in Midwest state in the United States. And they actually, this was people who were at a gender clinic. So all of these were transgender people. And they grouped people into either people who had never received any kind of gender affirming care. So no surgery, no hormones. Some people who had experienced hormones only, but no surgery, that's the yellow. And then purple is those who had access to hormones and surgery. And so what I think is quite interesting is that the lowest sort of EDEQ scores here were among the people who had access to hormones and surgery, which in general, shows that receipt of gender affirming care, hormones and surgery is associated with lower, eating disorder attitudes and behaviors overall. But I think it's also important to note that there may still be issues with people, even if they have access to gender affirming care. Because interestingly, you see that sort of the highest rates were actually among people who did receive hormones, but not yet surgery, in the yellow. And again, this is just an observational study. And so, I think there are probably other factors that aren't accounted for in this study, like perhaps people who didn't have access to hormones or surgery, may be different in some ways than those who did access care. Like perhaps they didn't want hormones or surgery yet or something. But it's just, I think, important to see that in general, there may be lower concerns with eating attitudes and behaviors for those who really can access all gender affirming care. But that doesn't mean that they're not going to be body image and eating disorder concerns. The last kind of clinical conundrum that I wanted to mention was just for transgender youth who are growing, which growth chart do we use? This is a big debate that there's no great answer to. But I just wanted to note that in the US, we often use growth charts from our Centers for Disease Control. I know there are also World Health Organization growth charts, but all these growth charts are based on just binary sex, so male versus female. And so there's no transgender growth chart, and it's always unclear which growth chart to use. So I briefly am just going to go through a few examples. And so here we see these are three transgender boys, so they were assigned female at birth. And I'll just briefly point out, so these are the same person, but you basically, if you track them along their growth, so like this person was growing along the 50th percentile, this person at the 75th, this person at the 90th. So the 50th is here, the 75th here, the 90th here on the two. This is the girls' growth chart, this is the boys' growth chart. Actually, if you see, there's not really a huge difference based on which growth chart you use as to their target BMI if you are following them along the curve. And then similarly, this is for transgender girls, so they were assigned male sex at birth. And if you look here, this person was at the 50th, very similar. This person was, these two were tracking at the 95th. And for this one, also kind of similar, but there was a little bit more of a difference, actually. The girl growth chart was higher than the boys' growth chart for this 16-year-old. So I guess if you get into the higher sort of BMI percentiles and older ages, there are like a little bit more differences. And then this was for these were for 4 non-binary or other gender people, and these were all overall pretty similar. So actually, if you look at these patients overall, actually, there was not a statistically significant difference if you use the male or female growth chart. So I guess I would just say that there's no current best practice guideline for which growth chart to use for gender minority patients. Some have suggested using growth charts based on the affirmed gender, especially if the patient has received gender-affirming hormone therapy. But I do think that it's not a one-size-fits-all. You should also consider the age, their current age, and also their pubertal status at the time of receipt of gender-affirming therapy, if they have received it. And you can generally, in our practice, we do both the male and female growth chart, and we compare them and see how different they are. But as you can see, overall, it actually doesn't generally make a huge difference unless you're older and at the sort of extremes of the percentile. Kyle already mentioned some of these barriers to treatment. So these, I think, apply for sexual and gender minorities. The one that's specific maybe to gender minorities is the access or lack of gender-affirming care, which can impact people's body image and eating disorders. And so with that, I want to thank you so much for the opportunity to present, and I will pass it on to the next presenter.
Thanks a lot, both. It was a very great presentation. It's an overview, very important, because it's opened the mind for all the clinicians, and it helps also to understand what we have to change in our practice to meet the needs. Thanks, Jason Nagata from San Francisco and Kyle Ganson from Toronto. Before to pass to the micro to Paolo Meneguzzo, I want to thank also Elissa Meyer. She's very important for us. She's helped us in every passage to improve the presence of the European chapter. And Dawn Gannon, because she's technical issue and capacity is the way that permit us to organize this kind of meeting. We have 4 presentations, both are presented until now, and we have also the opportunity to pose some questions using the chat inside the video. Now, Paolo Meneguzzo, is a doctor, he teaches in the University of Padua in the Department of Neuroscience. His topic is, I read, body and weight dissatisfaction, variation across sexual orientation. Paolo Meneguzzo, it's your time.
Thank you for the kind presentation. Thank you for the invitation. I'm very honored to be here with other people to speak about something that is very important from my point of view for the well-being, for the health of people, and for the improvement of the health of people. My speech will be about body perception, body weight dissatisfaction, and the role of sexual orientation on this aspect. I want to start making a definition of body image. Body image is the picture that everyone have in their mind about their body, and the judgments and the about our body. People usually have a neutral perception of their body, but sometimes there is a huge difference between what we see in the mirror and what we think about our body. From a psychological point of view, body image can be influenced by self-esteem, by depression, and by social comparison. Self-esteem is how a person values or accepts themselves, or who or what they are. Depression is one of the major psychiatric symptoms linked to body image and the dissatisfaction about body image, and is also linked to the difficulties in the change of the way we perceive and describe our body and our and the judgment of our body. And social comparison is something that Nagata told very well before me. That has a role in the build of body image and in the judgment of our body. I want to ask you to do a mental exercise. I want to invite you to think about 3 things that you don't like about your body, and then to think about 3 things that you like about your body. I think the majority of us can state that the hardest exercise is to think about something that we like about our body. We are pushed to change ourselves. We are pushed to improve our performances, to improve our appearance, and so for us, for all of us, it's easier to think about something that we don't like about our body. And this is an aspect that is that makes complicated the treatment of eating disorder, because body weight dissatisfaction, like body image dissatisfaction, is something that is crucial in the treatment of eating disorder, because is somehow the core of the eating disorder psychopathology. Body weight dissatisfaction is linked to also to fear for fatness, and they are 2 constructs that are very present in early adolescence, and recently we saw that they are also very present in sexual minorities. They are both very linked to the Western society's the idealization of body image and the push to improve our appearance. For both Yeah, I think my slide is less inclusive that after the presentation before me. I think for all genders, the desire to change shape or weight is common. I think, yeah, this is something that I have to change in this slide. But why think about sexual orientation and body image? Because it's something that before a few years before now is something that was not so considered in the literature. This is a review from 4 years ago, and we looked to only to women, and we found that literature about sexual orientation and eating disorder was not so developed, and we found different results. We found contradictory results, and we thought that something we have to work for change this aspect, because sexual orientation must be something that people consider in the treatment, in the evaluation, and in the path for the improvement of their well-being. What we can say, is that lesbian women with more stereotypically feminine traits are more at risk of body weight dissatisfaction, and this is something that is not changed in the literature from the early 1990s to now. But this is not so. This is not enough. We cannot stay only to this information, and also we have to include other sexual orientation that are not so included in the research. For example, bisexual people. The first study, I want to present you is a paper that we published about the role of sexual orientation, the relationship between body perception, body weight dissatisfaction, and physical comparison. We collect information from a large sample of women and men, cisgender women and men, very representative for Italian people. They are quite old white people, and maybe this is a problem for the generalization of our results, but it's very linked to the to Italian, for example, and to Europe somehow. We asked them to use a figure rating scale, and we collect data from several psychological questionnaires. We found that significant differences were presented, especially for the comparison, for the physical comparison between people. And we found that sexual minority men, bisexual men, and gay men reported higher score of comparison, physical comparison, than heterosexual peers. As well as we found that heterosexual women and bisexual women reported higher comparison scores than lesbians. Something that we found that is similar to what say before me Nagata is that eating disorders symptomatology was higher in the gay sample. Then moving to the body perception, what we found was that gay men reported the higher misperception of their body size. Gay men were the only people who reported an over-evaluation of their sizes compared to all the other people that reported an underestimation of their sizes, as well as for body weight dissatisfaction, where bisexual women and gay men reported the higher score of the whole sample. If we look to attractive bodies, what we found was that was something that is quite is very common in the culture. If we look to Instagram or to the magazines, we found that female body were considered attractive with a lower BMI than the healthier BMI, so in an underweight status, while male body were considered attractive when when men are more with a BMI higher than the underweight status in the normal status. Yeah. So moving on to another aspect of the body weight representation and perception of our body weight, we look to the bias, to the weight bias. Weight bias is something specific in the eating disorder literature, because weight bias is the difference, the distance between the idea of my weight and the real weight that that is my the real one. For this study, we selected a smaller sample, always Italian people, and we asked them to fill the fat phobia scale. That is an explicit way to evaluate the weight bias in people, in general population. The fat phobia scale is very easy. There are 14 pairs of adjectives, and people have to decide the one that is more correct in their opinion to describe an obese person. What we found is that gay men reported a higher weight phobia and weight bias than the other population, than all the other population. And this is in line with the gay culture and the gay pressure for a muscular and lean body. And taking together all this data, so body perception, body weight dissatisfaction, and weight bias, what we can say is that sexual orientation have an influence on body weight dissatisfaction, has a role in in how people perceive and live their body, and how they can manage their body and the body image and their body image. In the first study, what we found is a significant relationship between sexual orientation in cisgender individual with body weight dissatisfaction and body size perception. And what I want to stress is the result for bisexual women, because they are people that are sometimes neglected in the literature. In the second study, what we found is the presence of a specific weight bias in gay men, especially, but also in bisexual women. So what we can say is that bisexual women and gay men seem to be the most vulnerable groups for body weight dissatisfaction. And this is something that when we performed the systematic review of the literature was not so clear in what we found, especially for bisexual women. But what we know and the research lines are moving on, and I reported here two reviews more recent than mine about the eating disorders, psychopathology in LGBT population, and what they found is more significant about the role of sexual orientation in eating disorder psychopathology. So what we have to do as mental health clinicians or therapists is consider sexual orientation as an aspect of the people, an aspect of the people that we have to assess and to consider in the treatment, because these aspects have a role in the body image disturbance and a role in the eating disorder psychopathology. And with this slide, I finish my presentation. Thank you.
Thank you, Paolo. Thank you, Paolo. It's a very interesting presentation. It demonstrates that between eating disorder, weight, body shape, sexual orientation, there's a link that we need to assess in the clinical practice. I want to underline also that in your first slide, there's the information for everybody that the University of Padua has its 800th anniversary this year.
Yeah, it's something that we are very proud of. Yeah.
There was exactly. There was there also Galileo, Galileo Galilei. Okay.
Exactly.
And now, thanks, Paolo. And now the talk from Manlio Converti. He's a doctor. He's a psychiatrist. He's the president of the AMIGAY, the Association of Italian Doctor Gay. Manlio, to you to explain more what are the needs and what they want from clinicians.
Thank you very much. I hope you can listen to me better than before, but I'm very proud to stay here and from the shadow to the light of the epidemiological studies that we heard from Jason Nagata, Paolo Menguzzi, and Mr. Gonson. But I'm actually not speaking about any specific research. We are not only a gay, but also a lesbian and transgender healthcare association. And we are working on what about is the studies in the world around healthcare and reporting this in the Italian and somehow also the European system, which is very far from the Anglophone countries as UK, USA, Australia, or Canada, because languages are very different, and also the mood of people, somehow also the way of life, and we must consider also all those differences when we are trying to give some advices when we are as professionals meeting and treating LGBTI people with eating and nutritional disorders. LGBTI people are a complex minority, as you say, which suffer severe discrimination from birth, including by their own family, and then by the school, social, sport, and work context, which can lead to a reduction in mental health or risky behaviors, also in the field of eating disorders and nutrition. And nutrition, because we are also speaking about obesity today. These mechanisms do not generally depend on the fact of being LGBTI as you could maybe misunderstood from the former professors, but usually on the consequent risk of the so-called minority stress or the reduced visibility, also called coming out in homotransphobic contexts. The fact of being LGBTI is consolidated to be a consequence of the epigenetic factors that occur in the first trimester as regards to the constitution of the genitals, which can be male, female, or intersex. And then in the perinatal, during the third trimester, when the brain is developing as regards the sexual orientation, gender identity, or gender expression. The most important thing to remember, there is no evidence of change after birth of any of those parameters. All we are, when we are trying to change them, we are calling them conversion therapies, and conversion therapies are absolutely very dangerous for LGBTI people. So, some of these epigenetic factors can be polycystic ovaries or the tendency to hypothyroidism of the mother, and these conditions inheritable in people born women, in addition to causing a greater frequency of LGBTI births, precisely causing women born a greater tendency to polycystic ovaries or hypothyroidism, with consequences in these LGBTI born women of greater obesity than the general population. We are speaking about lesbians, bisexual women, and transgender men. On the other hand, in male birth, the mother's polycystic ovaries, as one of the epigenetic factors, cannot be inherited, and it is the tendency to hyperthyroidism that maybe causes more LGBTI male births, with the consequences in LGBTI male births of greater thinness, because we cannot have any polycystic ovaries, than in the general population. And we are speaking about gay, bisexual men, transgender women before cross-sex hormone use. As regards the classification of a mental pathologies, and to ensure the depathologization of the existential condition of LGBTI people in all the countries all around the world, the institutional use of ICD-11 or following version is required. What you must learn today is there is no difference in mental health problems about schizophrenia, bipolar disorders, and obsessive compulsive disorders in LGBTI people. They are the same frequency than in other persons. But there is maybe some difference about personality disorders, autism, and ADHD for transgender people. This is something we are still questioning about. The most important point is there is a big difference, a huge difference, caused by minority stress and sometimes coping about anxious depressive pathologies, eating disorders, smoking, alcoholism, drug abuse, attempted suicide, and non-suicidal self-harm for the people that are born women, and effective suicide for the people that are assessed at birth as male. Especially the transgender and bisexual population could be affected by all of these problems because they are maybe the more distressed since birth by discrimination. What about depathologization? Depathologization is a concept that began from Dr. Anonymous, and then thanks to the World Psychiatric Association note in 2016, so in the 70s to 16, to the SOC 8 just wrote in the 2022, and then means that to be LGBTI is not a psychic problem. No difference for being LGBTI is written only in the ECD-11 manual. In the former one, ECD-10, there is some difference for being transgender. And there is a big difference also for being homosexual if you are using ECD-9-CN as in Italy. If you are looking to ECD-9, as I am gay, you could give me the disease number 302 point something, because we are using in Italy ECD-9. Since the pathologies of eating and nutrition have their basis or can begin in childhood or adolescence, it is necessary to pay particular attention to prepubescent minors and adolescents. They may already be able to self-determine, but it could be happen that they may be forcing crisis just to understand who they really are. This subgroup is called questioning. The institutional reception of future parents in gynecology, obstetrics, neonatology, pediatrics must also be taken into consideration to ensure every possible form of psychoeducation for the affirmative reception of intersex, gender variant, homosexual, bisexual, transgender, or questioning children and adolescents as your own beloved sons and daughters. Parents can also have problems with their own coming out as LGBTI parents, or for minority stress or anxious depressive states resulting from isolation linked to have LGBTI people into a homotransphobic context. And for this, they will need affirmative psychotherapy support also. It is the support for LGBTI visibility that guarantees, following the studies, the effective reduction of psychic symptoms, including disorders and nutrition, apart if you have polycystic or hypothyroidism problems. And this goes through specific support that we can divide into 3 steps. LGBTI inclusive data collection at each first access, affirmative reception of LGBTI people in the healthcare system, affirmative psychotherapy of LGBTI people and their parents. First point, inclusive data collection at each first access. There is not a standard about it. We have 4 axes to follow, and a 5th one is the visibility coming out. There is some difficulty in defining oneself sometimes, or in fully relating one's own sexual identity. You can help those people to understand what the 4 axes mean to help them. Greater discrimination could be supposed to be suffered for a lot of LGBTI people. And a lot of persons also remain in the conditions of questioning, as I said before, with respect their own identity for other reasons. Those are the 4 axes. Sex, you are born male, female, or intersex. Gender identity, who do you really feel to be? A man, a woman, or a non-binary person? Gender expression here is used in a different way, as Nagata before said. And in Italy, we prefer to use expression indicating effeminacy or androgyny or women more masculine aspect or voices, because this is something that impacts with the life of persons since their childhood and adolescence. And people can suffer a lot of discrimination and agree to discrimination also by LGBTI community if they are effeminate women with a masculine aspect or androgynous. Sexual orientation, we talk a lot about. I'm not explaining to you anymore. We tried to write a different system of sex and gender orienting, how we call the data collection, because the more used in all the papers you saw is in English. And the English is not the same than Italian, Spanish, French, Finnish, or German. This is very hard to use an English system. We must try, and this is just a draft, to write these questions about the 4th axis, and the 5th one is the visibility, into a plain way, into a way that everybody in any language could understand it. The LGBTI inclusive data collection, so, is very useful for having epidemiological data here in Italy, in France, because we only heard about data in UK and the USA. We need also to understand into the healthcare relation that the person we have in front, and also, third point, to help questioning people to better understand themselves. You must remember that anyone can be an LGBTI person. And since there are intermediate or fluid conditions such as bisexuality, it is necessary to ask anyone respecting privacy to respond to the data collection in order to allow them to respond clearly with respect to their own sexual identity. Second point, the affirmative reception of LGBTI people. Going to this point, it represents a support tool for the visibility into the medical, into the psychological, the medical, the nursing, healthcare relations. And this is very important also that we learn to have those people in their own private life as a mentors, with a mentoring for their own coming out or their own visibility without any greater risk of abuse. The affirmative reception must contrast elements of homotransphobia, also of health personnel. It must contrast elements of introverted homotransphobia, typical of those people who live in homotransphobic contexts, because sometimes LGBTI people hate themselves. They don't have self-esteem, and they have dangerous lifestyles because of introverted homotransphobia, because they don't build good emotional relationships with their partners or with their families or friends, because also in the family, the relationship could be very dangerous for LGBTI people if the homotransphobic element is their family. In this case, the introverted homotransphobia could be very strong. And we must help them to build good relationship at school, at work, in sport, at university, or in this normal society. Elements of homotransphobia of the context, especially the family one, must be contrasted. The affirmative reception also must allow the full definition and self-affirmation of LGBTI identity, whatever it is assumed by the person you have in front of you in this moment, including questioning intermediate and the fluid ones. What means that maybe next time you are meeting the same person, they could give you another LGBTI identity following their own fluidity. Respect for the chosen noun and pronouns or adjectives. This is the most important differences between Italian and English, between Spain, Spanish, or German, because in some languages, pronouns are very important to understand if you are speaking to a male or addressing to a male or to a female. And in English, you can also use the they for non-binary persons. In Italian, Spain, or French, I'm sorry, I cannot say in Finnish or in Flemish, adjectives, not pronouns, are the most important part of the phrase that you are using in the way to respect the identity, the gender identity of the person you have in front of you. And usually we don't have any way to address to non-binary people because our languages still doesn't permit very well to do it. Respect for hospitalization or the use of bathrooms also in a private place, for gender neutral places if you can, or for gender variant personal choice, respecting that choice. The presence of specific health material must be allowed in your own studies, in your own places where you work. And posters are not only with women and men and straight couples, but also with LGBTI evident persons. Also about only a rainbow, like in our flag here in the slide. And you must use in any form the inclusive personal data to allow the people to to see the represented personally. There is a lot to speak about affirmative practices point for global health, and also more about work simulation competencies and practice skills you could learn into a different, not here online. You must do it alive with somebody that is giving to you those competencies in the practice world. Going to the third and last part, affirmative psychotherapy of LGBTI people and their parents is a valid process for any style of psychotherapy. It's not a different psychotherapy, it's just a different process of any style of psychotherapy you use, which in addition to the two previous elements said already, works on various unconscious intrapersonal interpersonal, or social mechanisms specific to LGBTI people at the various age you are trying to help them or their parents. This is the most important work I'd say I found, the foresight. And we saw that also in Mexico, they did something similar. No? The Del Rio Gonzalez work is very similar. In this, you can see this slide, three kind of bars. The first one, and when you say, okay, gay people are the same than straight, transgender are the same than straight, and you don't specifically give them a psychotherapy. The second kind of bars are from conversion therapies. If you try to change our identity or our sexual orientation, the third one is what happens if you use the specific psychotherapy, the affirmative psychotherapy, where they are not eating, they didn't work about eating disorder specifically, they work on about anxiety, depression, suicide attempt, fatal suicide, alcohol, or substance abuse. And as you can see, do not do anything, or worse, to use conversion therapy is very causing bigger mental health pathologies to LGBTI people. Please try to learn affirmative psychotherapy and to use this when you have an LGBTI patient or parents with you. The main specific mechanism to be known and used in affirmative psychotherapy also for the context of eating disorders are especially the adverse childhood events, because those are very linked to the eating disorders, and those are very often they happen to be more into the LGBTI people during during adolescence and especially during childhood. To having undergone to genital mutilation, if intersex, as well as male or female appearance they have. The use under medical supervision for self-medication of hormones to block puberty or cross-sex. It could really change, as you also had seen before, the use of breast or male genital bandages, the use of breast, genital, larynx, or other body parts surgeries, the use of doping for gay and bisexual men especially, the use of pills such as botulinum under medical supervision or for self-medication, the use of abusive substances and the age at which they began to use them. Nicotine, alcohol, drugs are used former in the LGBTI people in the very early childhood because of the adverse childhood events, maybe. Having undergone or requested the so-called conversion therapy, because living into a very homotransphobic family, be part of an LGBTI center groups about eating disorder or nutrition, the eating habits with respect to the context of cohabitation with family of origin, a good one, and homotransphobic one, the family of choice, with specific good coping or bad coping that asks you to be more thinner or more muscle, a step family, or in solitude. Insight into the tripartite influence model, which has been also studied for having an influence on eating disorders, family, friends, and media, about thinness, musculature, body dissatisfaction, food restrictions, and physical activity. The standards claimed or expected by their specific LGBTI community, because they are very different. If you are a transgender man, a gay man, a lesbian woman, a transgender woman, or bisexual person, or an intersex person, etc. A presence of sexual body discomfort, in particular for transgender and intersex people, having previously activated affirmative psychotherapy path. We have a lot of guidelines already given, but not very specific about eating disorders. These are very general in psychopediatrics around the fact to have LGBTI clients for any kind of psychic problem. But we might, maybe with the help of the former professionals and also the people that are listening, the also professionals listening to us today and in the future, we are maybe trying to write guidelines in eating and nutritional disorders. There are a lot of those, as you can see. Latest indications as key points. The so-called reparative therapies and genital mutilation of intersex newborns should be prohibited by your country. It is appropriate to obtain the compulsory training in LGBTI gender medicine, psychology, nursing for health personnel and in health faculties as part of the curricula. And we are working about this. Please call us if you want to do it in Italy. It is also if we want to build an international network to obtain this in the whole Europe. It is necessary to follow a continuous training course on all the aforementioned materials, and especially internalized homotransphobia or internalized heterosexism, child abuse, current discrimination, visibility or concealment, involvement in a good or in a bad LGBT community. It is recommended to participate in the activities of LGBTI, whichever you are, LGBTI or not, maybe into an LGBTI workers association like AMIGAY, or in generalist association, including going to the Pride to get to know this reality personally and to spread the culture of care in this area. It is necessary to ensure a support network with other professionals to guarantee mainly cardiological checks, cancer screening, prevention of infectious disease, and social assistance. These are all our bibliography. Thank you. Thank you very much to everybody today here.
Thank you, Maelio. Your help is important to improve the quality of the services because we understand more after this webinar about the target group of LGBTI. We have 1 minute. If there are a question, we can use this minute in this way. Is there, Elisa? If not, practically it was a webinar full of suggestions. I thanks very much Nagata, Jason Nagata, Kai Genson, Paolo Manteguzzo, and Maglio Converti, because their support is important for the European chapter and for the European workers on the eating disorder field. I think that we can continue this kind of topic, considering the participant here, if they want, as a lab to promote the recommendation for the health services around Europe together. I hope that all the presenters today are members of this lab. And me, I think that we can organize another time using the very helpful presence of Dawn Gannon and Elisa Meyer, some clinical practice vignette where we can offer the opportunity to look at clinicians that met people with sexual orientation appertaining to LGBTI group. That can be very important to improve the teaching work that we are doing as European chapter. I want to remember you that the next webinar is on December 14, where we discuss together with the FITST, the largest group of career. And so it's another point to be allied with the career to improve the network to face eating disorder. Thanks to everybody.
Thank you so much. I'm so proud of all of you. And Umberto, thank you for your phenomenal leadership of the field.
I'm without words. Thanks a lot.
And this will be on the European website. I put the address in the chat box, but it'll be on the European website, a recording of it in a couple of days.
Okay.
So if you have colleagues that would benefit.
Thank you. Thank you to everybody.